Welcome. We're so happy that all of you could join us this afternoon for the DNPAO seminar series. Today's seminar will discuss the importance of childhood healthy growth. During this session, we'll highlight effective approaches that promote healthy growth in the early care and education and healthcare settings. My name is Eileen Basso. I'm team lead for policy and partnerships in the Division of Nutrition, Physical Activity, and Obesity, or DNPAO, as you'll hear it referred to today, and I'll be your moderator for today's session. I'm going to start out with just a couple housekeeping items. This Zoom call is being recorded. If you are not comfortable being on a recorded line, we ask that you disconnect at this time. We will be posting this session on our website at a later date, so you'll have other opportunities to watch it. To have the best experience, we encourage you to use the Zoom app or website to view the slides and participate in today's meeting. All participants will be muted. However, following the 3 presentations, we'll have a question and answer session. The Q&A box is open, so at any time, feel free to drop a question in. If you are using the Zoom app or website, you can type in a question by clicking on the Q&A icon, and we'll get through as many questions as we can during the hour. So for those of you who are familiar with DNPAO, you may be aware that the division supports nutrition, physical activity, and chronic disease prevention across the life course. Today, you'll hear about just 2 of the strategic initiatives for our division. Before we jump into today's session, I would like to introduce our 3 amazing speakers. So first, I have Carrie Doima. She is the lead for Early Care and Education Team, or ECE, in the Obesity Prevention and Control Branch in DNPAO at CDC. Carrie provides guidance and technical assistance to CDC grantees and partners on many facets of childhood obesity, including obesity prevention in the ECE setting. Dr. Allison Goodman is a pediatrician and medical epidemiologist in DNPAO. She's also a commander in the United States Public Health Service. Dr. Goodman serves as the lead for the Population Health and Healthcare Unit, also in the Obesity Prevention and Control Branch. Her role includes improving access and uptake of evidence-based prevention for childhood obesity prevention treatment, and she also manages a robust informatics and health services research portfolio. Jessica Wallace has been a family medicine physician's assistant for 16 years. She has worked at Denver Health, a safety net healthcare organization, since 2013. She has overseen the creation of a collection of effective pediatric and adult weight management programs into the SQHC setting to help reach underserved populations. She completed her Master of Public Health and Physician Assistant training at George Washington University. She is currently a doctoral student in public health at the University of North Carolina. So here's a quick peek at today's agenda. To kick off the session, Carrie will discuss efforts in the ECE setting to help children from birth to 5 get a healthy start. Allie will then talk about effective family healthy weight programs and efforts to support interventions for children and families with low income. Jessica will then provide an on-the-ground perspective from a federally qualified health center, or SQHC, in Denver. And again, then we'll have some time for Q&A. So with that, I'm going to turn it over to my colleague, Carrie, to talk about efforts to improve children's healthy growth in the ECE setting. Carrie?
Thank you, Eileen, and good afternoon, everyone. I'm delighted to be here with you today to talk about healthy child growth and childhood obesity prevention in the early years. Before we begin, I just wanted to share a few slides on childhood obesity and the importance of healthy growth. So here is a slide using data from the latest National Health and Nutrition Examination Survey, or NHANES, which indicates that about 19% of U.S. children and adolescents have obesity, including about 6% with severe obesity. Additionally, as you can see from the graph, obesity prevalence typically increases with age. We also know that there are disparities in childhood obesity prevalence. For example, there are disparities among racial and ethnic groups, with Hispanic and Mexican American and non-Hispanic Black children having higher prevalences of obesity, as you see on the slide. Also by household income, where children at higher incomes have lower levels of childhood obesity. Finally, location also matters, with higher obesity rates among rural children compared to urban. It is important to view these disparities with a lens of disparate opportunities for healthy living which often have historic and structural roots, which persist to this day. Why is healthy growth important? Well, we know that the risks of having obesity are numerous and serious, and you can see those on the slide. Obesity puts children at greater risk for a host of serious health conditions, such as diabetes, cardiovascular disease, as well as mental health conditions such as anxiety and depression. Obesity is also very expensive, costing the U.S. healthcare system approximately $173 billion per year. So how can we support healthy growth for all? Well, now with that background in mind and out of the way, we are ready to switch gears and really discuss this idea of supporting healthy growth for all children. Obesity prevention not only results in better physical and mental health outcomes, but also has broader school, work, societal benefits, as you can see outlined on the slide here. Which brings me to the topic I spend most of my days thinking about. This is the early care and education setting, or I'll call it ECE, where approximately 12.5 million children spend time. ECE can be an important setting for helping children build a foundation for healthy habits and can really influence what children eat and drink and how active they are on a daily basis. So ECE, well, education in general, first, is a key equity driver in the United States. And we know that ECE participation impacts short-term outcomes for children, such as health and school readiness. But there is also an extensive body of literature from many longitudinal studies that demonstrate that participation in high-quality ECE programs improves both long-term health and societal outcomes, including decreased substance use, decreased adult BMI, decreased cardiovascular disease risk, and also societal outcomes such as educational attainment, crime, and income. Studies show that return on investment for ECE programs is high, which are largely also societal. Thus, access to high-quality ECEs can also be a critical social determinant of health. For the past 12 years, DNPAO has supported work in this ECE space to improve nutrition, physical activity, and support breastfeeding for kids ages 0 to 5 who are in care. We really do this through a triple prong approach. Maybe people have heard me talk about this before, but really just thinking about first how we support states to implement national standards into existing state systems. Second, how do we help local communities and support ECE facilities, those ECE centers and ECE family childcare homes, to improve nutrition practices and policies and environments? And finally, how do we support providers or ECE teachers to implement those best practices that are tailored to their facility context and related to our topic area? We do this work through funding, TA, and surveillance. DNPO has currently 3 state-level cooperative agreements for ECE, for improving the ECE setting in 33 states. We also have 2 local-level cooperative agreements supporting 23 local jurisdictions. The reach of our programs is around covering about 3/4 of children under 5 in the United States. And we really encourage our recipients to think about and aim for sustainable change. And here are 2 examples of sustainable change that I just wanted to share with people. So first, we've seen improvements in state licensing and policy. This is a policy lever largely. So individual states are ECE providers are licensed by individual states. And we at CDC have been reviewing and producing an annual report on how well licensing regulations support our topic areas. And from 2010 to 2018, 39 states have updated their licensing regulations to include more physical activity, nutrition, and breastfeeding support. Finally, just thinking about that facility level change, the nutrition and physical activity self-assessment for childcare, also known as NAPSAC, is an evidence-based and publicly available intervention for the early care and education setting. NAPSAC is found to be cost-effective and also shows strong evidence for impacting early childhood obesity risk. Currently, 22 states are using Go NAPSAC to support ECEs in their jurisdictions, and some states are even reaching large proportions of childcare providers, including preliminary data from Iowa showing them reaching around 1/4 of facilities in 2021. Finally, this data can also be used for evaluation. So many of our recipients take and use the Go Knapsack data for evaluation as well. So with that quick overview of our ECE work and kind of some of the foundational statistics around childhood obesity, I'm going to turn it over to my good friend and colleague, Dr. Allie Goodman, to talk about child healthy growth in the healthcare setting. Allie?
It's a pleasure to be here today. So I'm just going to start with some context around COVID-19. It's hard to talk about children and nutrition, physical activity, and obesity without talking about the last 2 years and the impacts of the pandemic on children. The pandemic led to disruptions in food and nutrition accessibility, physical activity opportunities, education, sleep, and social connection for children and adults. But these had, really significant impacts for children, including increases in stress and mental health and coping, food insecurity, and really exacerbated disparities that were already there. And this has really put a spotlight on equity issues as it relates to all kinds of health and non-health related issues for children. We know that obesity results from how people respond to short and long-term disadvantage and the associated stress on their biological functioning over time. And the pandemic has just exacerbated these differences. So a couple of really important points to understand about the relationship between COVID and obesity. So first off, we know that among youth with COVID-19, underlying medical conditions, including excess weight, seem to increase the likelihood for hospitalization and severe COVID-19 illness, right? So kids with obesity seem to get more severe illness. So that is, a really innate biological interaction there. But also during the pandemic period, we know that because of the disruptions in sort of the environment and life, that the average rate of BMI increased really significantly. In fact, it almost or over doubled during the pandemic period. And those differences were even more exacerbated for children who started with obesity. There was also, or has been also, an increase in incident diabetes, and that's mostly type 2 diabetes among those less than 18 years old during the pandemic period. And there's also been an increase in emergency room visits for eating disorder conditions by youth. So overall, we're looking at, not a great time period for chronic disease risk among children. So now more than ever, we need to translate evidence to action in terms of prevention and treatment of obesity in children and adolescents. So in the healthcare setting, what evidence do we have? So we have some older recommendations from 2007 from the American Academy of Pediatrics, but we're really excited that in 2022, this fall, AAP will be releasing new clinical practice guidelines. We at CDC have had the opportunity to contribute and support those, and we're really excited those will be released later this year. We also have the 2010 and reasserted in 2017 U.S. Preventive Services Task Force Grade B recommendation for child obesity. And I'll go over those in just a moment. So what is that USPSTF recommendation? It says that physicians and other clinicians should screen children ages 6+ using BMI or body mass index and offer or refer children with obesity to intensive family healthy weight programs. So what are those programs? They should include at least 26 hours, which is a lot, we'll talk about that more, of counseling over 2 to 12 months on nutrition, physical activity, and behavior change. And I'll unpack that a little bit more as well. But I just want to be clear that these programs have a lot of evidence. Over 60 randomized controlled trials have shown us that these family healthy weight programs can promote health and well-being and result in a 5 to 20% reduction in excess weight, not only for children, but also for their caregivers. So DNPAO, we work in health systems across the pediatric care continuum, not only in prevention for children, which should be universal, but meant for kids with excess weight. So on the left side of the slide, in the prevention space, we're talking about screening all children. That means that we want, clinicians to be looking at healthy growth, to be observing healthy behaviors, screening for things like sugar sweetened beverage intake. We hope that clinicians are screening for social determinants of health, such as food insecurity that lead to obesity and overweight risk. and providing referrals to resources. We are hoping that they're using growth charts and using decision supports that help clinicians make decisions based on the best available evidence. In the treatment column on the right, again, hoping that clinicians are using the best available evidence from clinical practice guidelines, providing families with family healthy weight programs. We are working on trying to help support payer reimbursement, billing, and coding for these programs, which are major barriers to spread and scale of them in the field, and also trying to better support clinic to community linkage, because of course, most of obesity prevention and treatment occurs outside of the clinic walls. So just as an example of a space where CDC is trying to work with healthcare is in growth charts. So of course, CDC's growth charts are the mainstay, are the standard. And in the middle here, you'll see the body mass index growth chart that's been layered on with color coding, with green, yellow, and red. So an interpretation of our growth charts that really help clinicians and families to interpret CDC's growth charts. And we're really excited that later this year, we'll be releasing some CDC color-coded growth charts. Also on the right is a severe obesity growth chart. These are used by clinicians and families for children who are already living with excess weight, and they're a very helpful clinical tool. And again, we're working with the National Center for Health Statistics, which is a part of CDC, to release new severe obesity growth charts later this year. And we're really excited to be able to provide those as a tool for healthcare systems. So another major gap in the health systems field is packaging the existing family healthy weight programs so that they have all the components that are needed for successful implementation in all settings, but especially the settings that serve our lowest income families. And so what does that mean? We need to have the materials available in user-friendly formats with all the implementation manuals, the training curricula, with the technical assistance available, and evaluation and quality control materials. In other words, like a package that can be picked up and implemented in a federally qualified health center, in a community venue, wherever it is that you need to serve children and families. And so you also need to ensure that there's sort of supply, right, in terms of sufficient reimbursable interventions available, these packaged programs, and you have to have demand. So we need to make sure that providers are aware of these programs, that they're confident and that they're referring. And so we have a lot of health systems work to do to make sure that, that this is happening. So what are the components of these programs? So the content, again, includes that nutrition and physical activity skills and counseling, and that's a key piece. But really the focus is on behavior change, right? And we all know how hard it is to change our behaviors. And so that is really the mainstay of these programs. And they are family-centered because for children, right, like they're part of a family unit and part of a household. And that is a really key component here. They have to be very much contextualized and addressing the social determinants of health. And they have to be delivered with an awareness of body image, bias, stigma, and shame. We want to do no harm. This is really critical. Dose and delivery is also key here. We need a sufficient amount of quote unquote dose, right? So 26 hours over 2 to 12 months. And I know that sounds like a crazy amount, but it can be done. And Jessica Walsh, who's speaking next, is going to give us some information about how the actual real world of that. Booster dose or maintenance dose is important to sustain effects in the real world. In terms of setting, these can be done in clinics or in community settings by a multitude of different types of providers. Groups and individual sessions can be done and combined, and they can be done virtually or in person. So what are the benefits of these programs? They improve child and family wellness. Families come out of these feeling better in lots of different ways. They improve health behaviors, parenting, family stress and coping. And having just talked about the pandemic, I mean, how many families don't need help with family stress and coping, right? It's really great stuff. They improve quality of life, mental and behavioral health. This is key. Depression, anxiety, improve metabolic markers, right? Diabetes, lipids, fatty liver, blood pressure. Health quality measures, this is really critical for health systems, reduced or maintained child and caregiver weight. The programs have been shown to be cost effective, both for the child and caregiver, and even be cost saving, right? So these investments in prevention and treatment can result in later savings, which is really critical. So just wanted to quickly show on a map that our group is already funding through CORD, our Child Obesity Research Demonstration Projects. That's where we're packaging those programs, as well as the Commit Project, where we're implementing some of those family healthy weight programs in federally qualified health centers, which Jessica Wallace is going to speak to next, as well as some data initiatives through the CODI project across the country. So we have a number of initiatives, and we're looking forward to additional future spread and scale. So a few examples of programs briefly. This is just 4 of many that exist with decades of research funding. So one example is Healthy Weight in Your Child. Healthy Weight in Your Child is based on the MEND program. MEND is the Mind, Exercise, Nutrition, Do It program. It comes out of the UK. It has decades of research evidence behind it. The YMCA of the USA licensed MEND for like several decades. And so you can join Healthy Weight in Your Child at the Y, at Ys across the country. It's in a group format. It can be done virtually or in person. It's a 12-month program that includes 25 sessions that are led by trained laypersons, which is a really wonderful aspect of it. And there are opportunities for billing insurance. For example, in Milwaukee, Wisconsin, the Wisconsin Medicaid program is reimbursing $629, to be very specific, for Healthy Weight in Your Child, which is really wonderful that they're having Medicaid reimburse for low-income children and families to join that program. The Bright Bodies program is another example. It's a 12-week program. It can be done in the clinic or community setting, though most of their implementations have been in school-based health centers. It can be done virtually or in person. It is most commonly delivered by registered dietitians, but also has been done by social workers or exercise staff, exercise physiologists. It includes the same sort of components that you'll see standard as part of these: physical activity, nutrition, behavior modification, has a sort of separate parenting group as part of it. And there have been cost saving studies showing an average savings of $930 per child in over 10 years. So Bright Body is another wonderful program. The last example for today is the Family-Based Behavioral Therapy, or RISE program, which comes out of Washington University in St. Louis. Just wanted to have you focus on a couple of pieces. It is a behaviorally based program, so it's predominantly behavioral coaches who do the RISE program. And just wanted you to see that there's a really big focus on positive parenting. And talking about being a healthy role model for your child, using praise, setting limits and rewards. Wanted you to see that there's this one-on-one coaching aspects and setting goals, how it emphasizes using your community and engaging with community resources, and on building self-esteem, building body confidence, practicing healthy self-talk, all these wonderful skills that are good for all of us. Also in Missouri, there's a state plan amendment that went into effect this year to cover up to 70 hours per year of family-based behavioral treatment in the state of Missouri for children and adults. So really excited about that benefit going into effect, and look forward to hearing about the rollout of that program. So in summary, partners in many sectors are part of the solution. But what we want you to hear is that effective prevention and treatment exists that focus on healthy behaviors, right? In ECE and schools and communities and clinics. But mostly these prevention and treatment programs have to be adapted, right, at the local level for acceptability, community contact, and cultural adaptations. And that's how we get to equitable implementation. That's how we reach our hard to reach populations, our low income populations who really, really need our help. And what we hear time and time again is that families are looking for help and supports. We just have to get it to them in a way that they can, that they can access it. So with increased availability and access and coverage, which is another key piece, together we can meet families where they are, right? And support children's and families' health and well-being. And with that said, thank you very much for your time and for listening. And I am going to hand it over to our wonderful colleague out in Colorado, Jessica Wallace. Take it away, Jessica.
Awesome. Thank you so much. I'm really, really happy to be here with you all. I am a family medicine physician assistant. I've been a PA for 16 years. 15 of those have been working in federally qualified health centers. And I'm speaking to you today wearing two hats. I am the director of a collection of programs called Healthy World at Denver Health, which is an FQHC in Denver, Colorado. And I also work with the National Association of Community Health Centers on the CDC funded grant called COMMIT, which Ali just spoke about. And that stands for Childhood Obesity Management Models and Teams. And COMMIT is based heavily off of the MEND program, as well as informed by the U.S. Preventative Services Task Force guidelines, and also our years of experience around what works. So I'm going to help dive a little bit into implementation and practice. And what I mean by that is doing the work of taking public health programs and integrating them into healthcare delivery settings. I've done that first in Washington, D.C. in an FQHC network, and now in Denver. So this is just a map to orient, similar to what you saw earlier. So my healthcare organization is there in Colorado, but we also under COMMIT work with state primary care associations and FQHCs in Arizona, in Mississippi, Illinois, North Carolina, and Florida. And since we're talking more about the on-the-ground experience, my slides are just going to be pictures of kids and of families that are engaging in COMMIT and having fun while they're doing it. You'll notice we're not professional photographers, so they're just meant to be snapshots in the background as I discuss some of the successes, the challenges, and opportunities that we've seen in this translation from research, which is, of course, a very controlled environment, into the chaotic, messy, and beautiful world that we all live in. So first, the why, and by that I mean why take these interventions and connect them into FQHC. So like was discussed earlier, there's evidence is strong to show that intensive interventions are what work best. The USPSTF guidelines inform a lot of the work that we do within primary care. And so that does include how do we help our kids and families who are struggling with excess weight. There is a need, and we see it every day. And speaking honestly, in primary care, it doesn't feel good to not feel like you have more than kind of basic advice or counseling to be able to offer to patients. This is an equity issue. And so federally qualified health centers take care of patients regardless of their ability to pay. And so that means we mostly work in low-income communities, often communities of color. And how this translates is, on the individual level is, when I'm giving the advice about eating fruits and vegetables or other things like that, can that family afford fresh, healthy food? Do they have time to cook? Do they have quality physical activity programming, access to after-school activities, gyms, pools, et cetera? And this is a disparity issue. And as the data has shown, it's gotten worse during the last 2.5 years. And so we're trying to close a care gap to a public health emergency. The opportunities are there to implement these interventions in FQHC. So first off, I think historically, there's been a cool role for FQHCs as innovators in healthcare delivery. This includes things such as integrated behavioral health, substance abuse counseling, group models of care, and self-management. The other thing is that we're medical homes. And so often FQHCs are a stable and trusted presence in the community and neighborhoods where we work. And we know that connection to medical provider advice and recommendations means a lot to patients. And so by embedding these programs into where families get their care, it really helps stress how important and meaningful these kind of activities are. So this works. Over time, what we have seen with these programs is that we do have changes in health behaviors. We have improved weight-related quality of life, increased confidence and self-efficacy, and specifically in the case of our Denver Health patient population, the CDC actually helped us analyze some of our data longitudinally compared to controls, and saw change in BMI and blood pressure trajectories over time. So what we are learning over these last few years, first off, I have to say COVID's been a real bummer. I'm sure nobody on this webinar would disagree. But specifically when it comes to programs like COMMIT or intensive interventions, from one day to the next, it was suddenly not safe to continue in-person group programs, particularly for our patients who everyone realized were at risk, increased risk. And so a lot of the work had to go on pause, and then it had to be completely rebuilt in another format. And that disruption continues today, of course. Another maybe more positive thing that we're learning over time with this Commit project is that FQHC leadership and staff have been tremendously invested in this work. It really does fit into the mission of the provision of high quality care. I would also say we've seen that success, not just the health outcomes that I mentioned earlier, but also patient satisfaction. And they show us by coming and attending to these intensive interventions, which are hard for anyone to be able to commit to. Pun intended. And there's a dose response. So the longer and more engaged families are able to be, the more changes they're able to make. So this is definitely seen as a value for patients as well as a value for the staff of the organization. In addition, what we're learning is that we need those packaged implementation programs that Ali mentioned. These implementation programs can really help reduce some of the barriers to initiating. However, they really do need to be flexible. As an example, FQHCs have issues with workforce and turnover, which we're now all feeling as well as a society. And so you really have to think through, what are my training opportunities? How do I train up new staff when I need to avoid disruption? How do I provide refresher trainings? The other piece with these packaged interventions is that you really do need to take into account culture. That might be individual patient culture, culture of the community where you work in, culture of the organization you're at. But the reality that we've seen over and over again is that adaptations work to improve retention. And so how do you provide the structure to ensure fidelity, but also celebrate those innovations? The other piece is that the integration into primary care is really magical. FQHCs have behavioral health that you can connect people to those resources when they need it, sometimes to nutrition, certainly to medical, particularly for weight-related comorbidities, which we're seeing in very high numbers. But I have to, of course, say that this is outside of the workflow of primary care. So it's just acknowledging that doing these intensive interventions is a heavy lift. So what do we need moving forward? This is really about that dissemination and implementation science and that translation of research into practice. I strongly believe that one of the important steps to reducing disparities and making the world more equitable is to go where the need is. And FQHCs, I think, can really serve a big role in that. Sometimes with some seed funding, these health centers will come up with creative ways to staff based on their on-the-ground context and even opportunities to try and keep it going. The other thing that I think we need, and it's important to say, is that packaged interventions, you have to be able to reduce the burden to initiate and to continue. You have to avoid excess cost as much as possible. No surprise probably, but primary care and FQHCs are not the money-making side of healthcare. And so I think in an ideal world, a lot of these things would be free. And then in that vein, finding ways to encourage and celebrate local and cultural adaptations, and then kind of elevating those best practices for scale and spread. And that's all I have. That's my contact info as well as for NAC. And I'll turn it back over to Eileen.
Great. Thank you, Jessica. And thanks to all our speakers today. We now have some time for question and answer. I already see several coming in through the chat. So if you haven't already, feel free to drop something in. So let me kick it off. We're receiving some questions about whether BMI is an appropriate measure, how it applies to different racial and ethnic groups. Ellie, I know this is a question we get a lot in the division. Do you wanna take a stab at this?
Sure, I'll be happy to. So I think the first major point about BMI is that it's used both for tracking obesity in the population over time. So it's a population health measure, and it's used as a screening tool at an individual level, right, in the clinical setting. So if we start by talking about it as a population health tool, when looking at the population, the widespread and long-standing use of BMI has helped public health professionals make comparisons across time, regions, and population subgroups. So by tracking trends in population body weight over time, we can prioritize resources to support chronic disease prevention. So there are other measurements out there, right? There's bioelectrical impedance, DEXA, or dual energy X-ray absorptiometry, I can never say it right, and total body water, which can measure body fat. There's lots of other options out there, but they're higher cost, the skill level required, the time needed, make them really impractical to use routinely or for population health purposes. So I think the point of all of this is that for now, BMI is the most time and cost efficient screening measure for population health that's currently available. But now let's switch to the individual level. So, as a pediatrician and, for clinicians, when considering individual patients, BMI should be taken into account along with other contextual factors. So as a provider, once I screen using BMI, I further assess risk, right, through a history, a physical examination, and appropriate laboratory assessments if needed. So, for example, if I see an adolescent with a BMI at or just above like the 95th percentile, which is the cutoff for obesity among children, and on examination and assessment, I find that this adolescent is super muscular with an athletic build and without any other chronic diseases like blood pressure, evidence of insulin resistance or whatever, no significant family history, I'm not going to diagnose this patient with obesity because there's no evidence of excess weight for health or other chronic disease. So in this instance, the BMI is likely elevated due to high muscle mass and not due to excess body fat. So now let's talk about BMI and the increased risk for mortality and morbidity among certain racial and ethnic groups. And I'm sorry, this is sort of a long answer here. So while BMI alone shouldn't be used to diagnose obesity in individuals, a USPSTF, that's the U.S. Preventive Services Task Force review, did find good evidence that BMI is reliable and valid for identifying adults at increased risk for morbidity and mortality due to overweight and obesity across gender, racial, and ethnic groups. So even for those with normal blood pressure, blood sugar, cholesterol levels, right, having overweight or excess weight alone can increase the risk of heart disease and severe outcomes from COVID-19, right? So we just saw this in the pandemic and, research and outcomes and everything. So there's something really there. So in essence, I think, BMI should not be used as a standalone measure to diagnose obesity on the individual level. And instead, the standard of practice is to take the initial BMI screening and to use the results when you're further assessing the patient, right? Like you have to look at the patient in front of you. And BMI is not perfect at the nuances. It's not always going to be perfect across racial, ethnic, or socioeconomic categories, but per the guidance that I get from our professional groups and et cetera, you have to really just take things into account. And this is one reason why major health organizations, including CDC and WHO and NIH and the American Medical Association, continue to recommend using BMI to screen all individuals, regardless of their race, ethnicity, who could benefit from additional follow-up with a healthcare provider. And that's the point, right? It's a screening measure because we want to make sure that we're catching people who need additional follow-up with a healthcare provider, and so that we can do more good, ideally, than harm.
Great. Thanks, Sally. I know this is a complicated issue, so we appreciate you taking the time to kind of walk through it step by step. I'm seeing a lot of questions about concern about talking with weight with children, that maybe it's not effective, that it can be harmful, that there's this risk with eating disorders. I think it really comes down to weight stigma and bias. So Jessica, I would love to hear from you how you integrate principles of health at every size, avoiding this weight stigma and bias in these healthy weight interventions. And then Allie, I know this is something that you think a lot about as well, so feel free to jump in.
Yeah, thank you. I'll start. I have lots of thoughts and feelings about this, but also have to acknowledge that I don't think that on the ground that we're at a place where we're in some ideal future state yet. It feels like something that is definitely still evolving, and even in terms of how our team and how our organization is trying to learn and improve. At a base level, I do think that weight stigma and bias is very real, and we've been trying to learn from patients, particularly adult patients who've, kind of helped share their lived experiences and kind of use that to inform how to ensure that the medical system doesn't do harm. I think on a practical level, we do still look at BMI. And so it's not throwing the baby out with the bathwater, but we are thinking very, very strategically around how to have those conversations with patients and families, how to certainly acknowledge that, weight matters, but it's not a one-to-one correlate with disease. And so to the extent possible that we can expand resources for everyone and not use BMI as kind of a gateway between who gets what intervention or not. And also thinking about other ways to define success and really elevate patients and families and let them help determine, what success means to them, what being healthy and happy means to them. And again, really kind of celebrate and work with patients on those goals as well.
Totally agree with everything that Jessica said. And I think when you're talking about children and families, I totally get the concern, and I agree with the questions in the chat, right? Like rule number one of healthcare is do no harm. We don't want to hurt anyone here. And I understand that concern, but I also don't think it's a reason not to intervene, right? So we have to learn how to intervene the right way. We don't want boom and bust diets in anybody, never mind in children, right? That's not helping anyone. But what we're looking for is building healthful habits. What we're looking for, right, is happy and healthy people who feel good about themselves, who have less anxiety and depression and good coping skills. What we're looking for is healthy, functional families. And that's where, what Jessica showed you is, these wonderful group counseling, sessions. You can see how integrated they are, like, and they're so behaviorally based, and they're helping families to do what they do better, right? So I understand the concern. We don't want to lead to disorder at all. I can tell you that research-wise, the RISE program that I mentioned earlier, the family-based behavioral treatment, one of the lead researchers from that program is Wolfley. She is a lead researcher in the US on eating disorder. They track eating disorder very carefully in all of their research, and they track that harm measure very carefully. And they do not find increased risk of eating disorder. And they have published out the wazoo, and people have picked up on a lot of the best practices from their publications, from their work, and integrated it into programs like Jessica's in Colorado and programs in the country. And we're making sure that CDC, as we're helping to promote spread and scale, are picking up on those best practices to, again, make sure we're not, accidentally hurting anyone. But there's so much hesitancy in healthcare. Talk about some of these of our own provider stigma or bias when effective treatment, and not just these programs, there are effective medications now, right? And for kids and adults who have a lot of excess weight, bariatrics is also a really effective option. And we need to be offering that from healthcare to patients and families. It's not a good public health solution, but it's an important, healthcare solution. So just putting it out there that, we have to kind of take this on, especially when 1/5 of children are affected by this disease already in childhood.
Great.
Oh, and I forgot
Ellie.
Person's first language, Eileen, sorry. Which I think is what we're trying to say. Sorry, the other thing that we want to do is make sure we're using really kind, a person first language, that we're not stigmatizing with the words that we use as much as possible. And so a person who is living with obesity, right, they are living with a disease, They're not an obese person. Just like if I had diabetes, I wouldn't be a diabetes person, right? Or a cancer person. I'm a person living with this condition. And so we just want to speak to people in a kind and respectful way about this condition that they live with. And often they're going to live with this for a good portion of their lives. And so we just want to be creating an environment in which people feel comfortable engaging with healthcare.
Thanks, Sally. That was great. Next, so Carrie, you discussed access to quality ECE as it relates to health equity. I know we have talked about it as a social determinant of health. Can you tell us a little more about that?
So yeah, CDC defines the social determinants of health as conditions in places where people live, where they learn, where they work, where they play, that affect a wide range of both health and quality of life and other outcomes. So really, if we think about the importance of education as a social determinant of health first, and then we kind of hone in on that idea that I kind of presented of access to high quality childcare or early care and education and what that really can do for children and families. The evidence is very clear from those longitudinal studies that interaction with high quality ECE really can impact in 30-year outcome studies, those things that we care deeply about. So I think really just thinking about this idea and this movement that we're having as a country to think about how we care for children and how we can provide for and see this as an opportunity by accessing high quality ECE to kind of perhaps achieve more equitable outcomes is something that I'm really excited to watch here as we think as a nation about young children, how they're cared for and those kinds of things and how that might affect us in the future.
Great, thank you, Carrie. So I see we have a lot of folks at the local level on the call, and we have one question about how local government can partner with local FQHCs to encourage the continuation and implementation of some of these programs. Jessica, do you have thoughts on opportunities for partnership? Or Allie?
I would say, I think, starting to create those connections and those relationships is an awesome first step. I mean, there's such overlap in terms of the work. And I think also that mission of what we're all there for. Sometimes healthcare can be hard to get in the door and even get somebody to answer an email. It's just because we're really overwhelmed, but, don't give up. And again, where are there opportunities to provide even some opportunities for seed funding? Where are there opportunities to kind of share patients back and forth, or, programs can occur in any kind of setting, whether you refer out to something that's community-based and supported by local government, whether local government provides some seed funding to be able to implement in the FQHCs. I think there's lots of ways to do it, but I think there's great potential with that kind of a model.
I agree. I think that's a great point. I also, we've seen, like in Denver, a number of local communities have some real luck when they can get multiple organizations that are serving children together at the table, including healthcare. And when you can get parks and recreation along with ECE, along with WIC, along with healthcare, at sitting at the same table, and everybody kind of says, oh, geez, we're all waking up every day, in the morning to serve these same children. We're just doing it in different ways. It really helps to open this dialogue and start sharing information. With that said, we have a cooperative agreement with the National Association of Community Health Centers, and I think can open some doors if you're looking to engage with a FQHC in your local community. And so if that's a particular interest in your community, I think you'd be more than welcome to email our policy group, and we can help to connect you, to try to help at least start making some connections for you to at least shake some hands.
Thanks, Allie. And I forgot to mention earlier, we have people in the chat adding some resources and links, so feel free to take a look there. They're helping answer questions as well. Carrie, we're getting a question. We have an ECE provider in Hawaii And we don't have the NPAO programs there, so she's wondering what other resources and programs might be available in her state.
So CDC, is funding 16 states across the United States in the SPAN program, the State Nutrition and Physical Activity Program. But also we do have folks who are in unfunded states listed as ambassadors and ambassador states. So that's a great way to get in contact with those who are working on nutrition and physical activity through that ambassador contact. And then also, I think the person mentioned, I can't see the chat exactly, but something about the farm to ECE work. So I think that's really great too. That work, CDC has a cooperative agreement with the Association of State Public Health Nutritionists to work with 10 states in DC around the farm to early care and education topic. So there's a lot of movement and momentum on that as well. So I'm happy to provide some follow-up links of ideas and ways to think about how to connect at the state level, but reaching out to your state, either in nutrition contact, chronic disease department, or others is a good way to kind of get started, and we can help facilitate that.
This next question, I'm going to throw out again to both Jessica and Allie. So one of our participants is wondering what your experience has been working with group settings as far as confidentiality issues and comfort level.
I think groups are amazing. And, I will say that as a clinician who, does most of my work individually with patients, and it's a little Groundhog Day, knock, knock, to start over and have the same conversations over and over again. And that's beautiful and wonderful too. But I think there's real power in groups. It kind of disrupts the otherwise hierarchy that exists within medicine, where one person is the expert and has the power. Groups can really kind of elevate everyone and help with people learning from each other, feeling empowered to say what their experience is or what they really think when somebody tells them that they, need to eat more vegetables. And so I love groups. And I will say within healthcare and within FQHCs, we do a lot of different types of groups. When we were first kind of building out our program in Denver, we used our experience with centering pregnancy and centering parenting models through the Centering Healthcare Institute. And what I would say with all of these groups is you absolutely start with, expectations of confidentiality. You do that with within the group, kind of deciding the group rules in their own words and their own standards for how they communicate and what gets shared or doesn't get shared. Not everything is taken care of within the group, which is why a lot of these programs then build on other layers that can connect back to behavioral health or to medical providers. And that's where anything that is not fit for group discussion can still be addressed. And again, like the power of the group to really be able to have a longer period of time with people, to be able to work with them over a period of time and watch them support each other and build these new connections and relationships is beautiful.
Yeah, I can just add, Jessica has that on the ground experience that there's quite a few of these family healthy weight programs that are really solidly evidence-based. And there's some that have, I think all of them, I believe, have at least some portion of group component, and they found that to be really important for the social connectedness piece, and for children and families to engage with each other. And that seems to be a really important piece of this puzzle, right? To helping families and others connect and kind of come to this better place toward the end of it. And there's certainly plenty of precedent for group setting work, as Jessica mentioned, in chronic disease prevention and treatment.
Great. Thank you so much, Ellie. So I can't believe our hour is already up. We're coming up right on 3 o'clock. So I'm sorry we weren't able to get to everyone's questions. Again, it's a complicated issue, and we can see that from all of these questions. And so I just want to take some time again to thank our 3 presenters for taking the time to do this, and for everyone who participated in the call. We know everyone's busy, and so taking an hour of your day to talk with us about these really important topics, we really appreciate the time. I'll close with saying keep an eye out for our next seminar series, which we plan to hold in September. We'll be putting out some announcements for that in the coming weeks. And again, we plan to post this session on our website, so keep an eye out for that as well. I hope everyone has a great afternoon and a great 4th of July weekend. Thanks so much.